on the Ceftazidime Avibactam and an update on the newer antimicrobials. So Ceftazidime avibactam is a molecule which is newly been approved by the US FDA in the year 2015. So the molecule ceftazidime was approved long ago. So this was a newer part which avibactam came into the role, and we started this combination, and it was approved in 2015. So this combination was been approved in the phase 2 trial. This was not that usual because US FDA only approves drugs after the third phase, but as ceftazidime was a very old drug and it had quite a bit of activity against gram negative and Pseudomonas, so it was a known drug and the safeties were established already. So we have seen that ceftazidime had a very good role before earlier. So avibactam was the newer addition to this, and with the data which we got from the phase 2 trials, we have seen that it was quite a bit promising. So, coming down to the introduction of the drug, so with the recent expansion of multi-drug resistant and pan-drug resistance, so we have been seeing the antimicrobial resistance quite a lot these days. So, antimicrobial resistance is the leading cause of death currently in the world because we are facing a lot of resistance from the antimicrobials, and we don't have newer antibiotics in the pipeline so much that this infections can be fought. So ceftazidime avibactam was the newest addition and was approved in 2015, which showed promising results and is actually effective. So it was the ones when we have been very much threatened with the pan resistance drug, mainly with the pan resistant Pseudomonas or the Klebsiella or the CRDs. So basically, it works against the carbapenem resistant organisms, the CREs, the carbapenem resistance enterobacteriaceae. So the carbapenem resistant enterobacterial CRE drugs are the main reasons for the hospital acquired infection. So the emerging CREs represent a threat to the global public health, and we are facing a lot of CRE cases over here. And extremely, we are very much saddened that we don't have newer antibiotics to cure them, like meropenem, artapenem. None of these are actually that much effective against these CREs. So studies have been conducted that CRD has a very high burden to the patients, and it has a substantial longer length of stay in the hospital because hospital acquired infections are common, and along with that the mortality is also high. So carbapenem resistant enterobacters are very much notorious and have a very much challenging in treating them nowadays. So this is where ceftazidime avibactam comes to the play. So a meta-analysis evaluating the numbers of deaths attribute the CRE infection was found to be 26 to 44% of the deaths across 7 studies were attributable to carbapenem resistance. So this was study was done long back ago where we have seen that 26 to 44% of the deaths were across due to carbapenem resistance. But nowadays the numbers are even higher, and the numbers are quite a bit terrifying. So coming to the next slide, can you please turn to the next slide? Yeah. So this is a combination of third generation cephalosporin and a novel beta lactamase inhibitor. So cephalosporins, as we know, it's a beta lactamase group of drugs. So beta lactam group of drugs, we have studied there are 5 generations of cephalosporins over here throughout the period, which included the third generation, and ceftriaxone is also a third generation along with ceftazidime. Ceftriaxone is also being used quite a bit, but ceftazidime had a better coverage for Pseudomonas. So, and the uh, Avibactam is a novel beta lactamase inhibitor. So beta lactamase inhibitors are earlier there, but this is unique to its kind because this has a reversible property. So we will be getting that into the later on slides. So it binds to the penicillin binding proteins, thereby inhibiting the bacterial cell wall synthesis. So cell wall synthesis is the main problem where the resistance come into play. And ceftazidime binds to the penicillin binding proteins, which inhibiting the bacterial cell wall, and avibactam protects the border and the beta lactamase. So the reversible part plays into role where the ceftazidime is also being saved along with the avibactam. So this is a newer concept which was brought and is currently being used. So earlier in 2015, we have seen that this drug was approved, and currently we are in 2023. This drug is also showing resistance, which is quite a bit shocking because this drug is also now getting resistant. I don't know what is next, but this is the only option we are currently having in hand other than the colistin, polymyxins, or any other kind of drug. So avibactam was the main key product which binded along with ceftazidime and was treating the patient with complicated infections like UTI or intra-abdominal infections. So coming to the next slide. So the indications where it was approved earlier in the first case in 2015 was complicated intra-abdominal infections and UTI. So in UTI, which were very much notorious to treat, where the only choice of drugs earlier was either colistin or fosfomycin, but they have very much higher effects and have severe toxicities as well. So in complicated intra-abdominal infection, you have it was earlier approved with treatment with metronidazole along with ceftazidime avibactam, and with UTI it is quite a bit effective. We have seen in multiple studies. Coming down to the next indication, which was later added on, was pyelonephritis. Please go back to the earlier slide. And in ESBL gram negative infections. So then later on, when we are observing the clinical outcomes of ceftazidime avibactam, we saw that carbapenem is producing bacteria, which are the KPCs. So KPCs were also being covered and associated with HAP and VAP, the hospital acquired pneumonia and the ventilator associated pneumonia. These were the main things because KPCs are very notorious, mainly E. coli and the Klebsiella. Klebsiella is the leading cause for the HAPs and the VAPs. So when a patient is ventilated, intubated due to this, we are already having some kind of respiratory distress, and followed by if we get an infection such as KPC, it's very difficult to treat because certain of the drugs doesn't reaches the lungs as due to decreased penetration in the lungs. For example, TG cycline, if we take TG cycline, is very difficult to penetrate to the lungs. It is mainly indicated for the skin and soft tissue. So where we are looking at is currently that it was very much widely preferred for HAP and VAP. So coming to the next slide. So the recommended dose, what is the dose for ceftazidime avibactam? So usually we see the dose of ceftazidime avibactam as 2.5 gram, which consists of 2 grams of ceftazidime and along with zero point 0.5 grams of avibactam. So it is recommended dose is 2.5 gram every 8 hourly over a period of 5 to 14 days depending on the infection. So in complicated intra-abdominal infections, we have to give it for at least 5 days and maximum up to 14 days. And in UTIs, it is also used for thrice daily, every 8 hourly for 5 to 10 days. And for hospital and ventilator acquired pneumonias, it is usually being given for 7 to 14 days. So usually the dose is 2.5 gram TDS, which is thrice daily or TID. So depending on the creatinine clearance, if the patient is having a history of CKD or acute kidney injury or creatinine clearance, depending on the patient's height and the body weight and the creatinine level, if it decreases, then we have to do a renal dose modification. If the patient's creatinine clearance drop by supposedly 30 ml per minute, then we have to reduce the dose to 1.25 or even lesser than that with a frequency of around supposedly frequency of BD or also once daily, twice daily to once daily. So depending on the dosage, we are calculating the actual frequency. And the infusion time, what is should be the infusion time for ceftazidime avibactam? I usually get this question because this is a newer antibiotic and people don't know what is the rate of infusion. So the rate of infusion should be around 3 hours. A prolonged infusion for a beta lactam is better because the more it will stay in the blood, the more it will act, and the more it will be having beneficial for the patient. So 3 hours infusion is the recommended for ceftazidime avibactam. And before starting any antibiotic, I will highly suggest to give a skin test or a test dose to the patient to check for any kind of reaction. If the patient is having any kind of reaction to cephalosporin, supposedly. So a test dose should be given to the patient first, followed by giving the full dose. So coming down to the next slide. For the dose in the pediatric patients, it is very unlikely to treat pediatric patients, and while severe infections are getting very much common, so patients with 6 months to 18 years old, we are also using zavicefta now, ceftazidime avibactam. So the dose is recommended is 50 mg to 12 mg per kg, maximum of 2.5 gram every 8 hourly, and the infusion time should be as high as 3 hours or even more. So the for intra-abdominal infection, it should be around 5 to 14 days as indicated, and the treatment should be the same for complicated UTI. So for hospital-acquired pneumonia or ventilator-associated pneumonia, it should be also given in the same dose, 50 mg per kg per day or 12.5 mg per kg per day. 50 mg per kg per day is for the ceftazidime, and 12.5 mg is for the avibactam concentration. So the infusion rate should be as high as 3 hours, and infection due to aerobic gram-negative organisms in the patients with limited treatment options. So in the limited treatment option, it should be around for the same for 40 mg per kg, and subsequently the dose for avibactam will be 10 mg per kg, and the infusion time should be around 3 hours. Coming down to the next slide, the novel anti-CRE. The novel anti-CRE is the ceftazidime avibactam, and it is a new beta-lactam. Beta-lactam is inhibitor, and its combination is approved by the US FDA, as I told earlier, in the year 2015 for the indication of complicated intra-abdominal infection, complicated UTI, and hospital-acquired pneumonia. So this hospital-acquired pneumonia is very common nowadays. If we go in a multi or super specialty setup, we will definitely find this. It can be a community acquired pneumonia, and the patient can also have a hospital or a ventilated associated pneumonia. So pneumonias are mainly due to this KPC organism, which are mainly E. coli or Klebsiella. We mainly find that the Klebsiella is dominating. Other than that, there are organisms like mm, Acinetobacter. These are also notorious and can be a leading cause for these infections. So ceftazidime avibactam is signaled as a turning point in the treatment of CRE, which is the carbapenem-resistant Enterobacterus, KPC, and partly for OXA, which is also a type of carbapenemus. So OXA is a group of carbapenemus which are having around many categories, which we mainly see in our setup is the OXA 48 and OXA 23. So these were the first indications which were approved by the US Food and Drug Administration for the treatment. But later on, we are using ceftazidime avibactam for many of the cases, and it is the last line of treatment currently. We are working on it. So it is also now showing resistance because this is the only drug remaining. Coming to the newer one, the clinical efficacy of ceftazidime avibactam. So the indication which we are looking at, can you switch to the next slide? Yeah, in the complicated intra-abdominal infections. So if it is the KPC, the organisms such as Klebsiella, or it can be a gram positive organism also. So ceftazidime avibactam is as effective as meropenem when combined with metronidazole in patients with carbapenem resistant organism, as well as in complicated intra-abdominal infections. In complicated UTI, we prefer doripenem, which has a higher concentration in the urine, because it will be passing through the bladder very fastly, but doripenem has other complications where the patient may develop resistance to carbapenem. that is where the ceftazidime avibactam come into play, and we can treat the patient better with this, and we are having better clinical outcomes on this. So hospital acquired pneumonia and VAP, it is like effective against all this, and where mainly the organisms are KPCs. So pathogen detected with ceftazidime resistance. So if ceftazidime resistance is there, as we are seeing resistant to carbapenem, it is not that or unusual to see ceftazidime resistance, but due to this novel molecule of avibactam, we are seeing that this can be used for the complicated UTI and intra-abdominal infections. So coming to the next, how this mechanism of resistance of CRE or the carbapenem resistance enterobacteriaceae, we are working on it. Next slide, please. Yeah. The five big carbapenems of particular relevance, which are the main notorious ones, is the KPC, the Klebsiella pneumoniae carbapenemes, the IMP, imipenemes metallobactam-lactamase, NDM New Delhi metallobactam-lactamase, VIM, which is Verona Intero encoded metallobactam-lactamase, and the OXA group, oxacillin carbapenemase. These are the five carbapenemes we are observing very much. And now coming down to like KPC, we are also having patients with NDM, VIM, and OXA over there. We are finding traces of that because we are already getting patients with Klebsiella pneumonia, and the patient is intubated. We are suspecting it's a VAP. We are also detecting NDM, VIM, and OXA 48 along with that. So multiple infections at the similar time where the patient is having higher chances of resistance, we are using and having very limited options. So where did this resistance develop, we are having a lot of difficulties for the treatment. So the treatment options are very much limited. So the treatment for CRDs are limited as we have discussed. So the antibiotics which have the potential against the carbapenem resistance enterobacteriaceae may be used alone or in combination. So I'll give you the pros and cons of using this alone or in combination. If I'm going to treat a patient with just simply polymyxin B, a high dose of polymyxin B, or the polymyxin class, which includes colistin as well, the usual dose of colistin will be around 9 lakh units as loading dose, followed by 3 or 4.5 depending on the patient's renal clearance, and followed by fosfomycin. So it is also a very known drug for the treatment of UTI, and it is very much has a very good capacity in the urine. So but fosfomycin has some kind of delay and has some severe effects in the potassium and the sodium level in the bloods. TG cycline is a very good choice of drug, but TG cycline has does not penetrate to the lung. TG cycline has also a higher reaction per severity. Like if we give a patient with TG cycline 100 mg twice daily, the patient will have antibiotic associated diarrhea, which can also lead to Clostridium difficile infection. So, side infection is also very much common, which we are the antibiotics which are using, and aminoglycosides. These are like amikacin or gentamicin. These are an option, but it has so higher toxicity, and the patient's kidney will just fry up if we use it in a toxic dose or in a higher dose. So, aminoglycosides we try to avoid. Polymyxins is a very good choice, but ceftazidime avibactam is a better choice in terms of the view. So I will prefer ceftazidime avibactam any day over this. However, the concerns remain regarding the increasing resistance and limited efficacy along with the toxicity. So ceftazidime avibactam does not have as higher toxicity compared to polymyxin B or TG cycline or aminoglycosides, which are very much having an effect on the kidney as well as sometimes in the liver. So coming to the next slide, we'll be looking into a study with a clinical experience with ceftazidime avibactam for the treatment of infections due to multi-drug resistant gram-negative bacteria and the carbapenem resistant enterobacterialis. So this study had 41 consecutive patients, which was treated for over 72 hours of ceftazidime avibactam for multi-drug resistance gram-negative bacteria. So these gram-negative bacteria mainly are uh, KPCs, acinetose. These are the mainly the gram-negative bacteria infections other than the CRE. Okay, so now coming to the median age, the patient 62 years is the median, where we have seen that 28 of the 41 patients were male and the remaining were female, and interquartile range was 41 to 70. And the patient having cardiovascular diseases was 14, and the percentage was 34.1%, and the CKD patients were around 9 out of the 41, and in 34 patients more than one underlying disease was present. So this was the main thing which we are looking after, that the patients are having multiple infections with multiple organisms at the same time in the hospitals, because hospital acquired infections are quite a bit high in the scenario we are living in India and in the Southeast Asia and the South Asia. We are having higher incidences of hospital acquired infections, and these organisms in the hospitals are resistant to all the drugs. That's why we are calling it a multi-drug resistant or an extreme drug resistance organisms. So 24 of the patients were with sepsis or with septic shock. So this is the alarming, where the patient is having sepsis or septic shock, means the patient is going with the organ failure, and the organ failure and the injury to the organs have already been started, and there are changes in the patient's blood level, electrolyte level. So 10 of them were admitted to the ICU due to the gram negative infections. It is quite a bit common if we see a gram negative organism in the blood or in the urine, the patient is likely to be in the ICU. So coming down to the next slide, if we see the microbiology of it. So these are the antibiotics which we are having over here, which we are having amikacin, cefepime, ceftazidime, ceftazolone, tazobactam, ciprofloxacin, colistin, gentamicin, imipenem, meropenem, and the piperacillin tazobactam. So out of this, the restricted ones I will say is the colistin and the carbapenem group. So ceftriaxone is not there because we will start the patient as the first line of antibiotic. If we suspect an infection, it will be ceftriaxone for currently using standards, or it can be a choice of piperacillin tazobactam. So we are not preferring amikacin that much, but over here the study shows that out of 45 patients, 25 patients received it, and around 20 patients have been recovered for the uh, ESBL has been 5, and for cefepime it was 7 for the ESBL, and ceftazidime is showed 7. So obviously we are seeing higher resistance. So the multi-drug resistance can be seen in the 41 patient study which we have seen in the microbiological aspects. Coming to the next one, if we see the cure and the failure. So 90% were cured, but in the bone infection, we can see that is 100% clinical cure. Okay, and the failure level was high in the intra-abdominal infections, which was around 25%, but other infections it was cured. So ceftazidime avibactam was having a higher resistance, and the failure level was high in the intra-abdominal infections. So obviously we are seeing higher So next, coming to us, familiar study which was published in the MDPI antibiotics. It was a review article on ceftazidime avibactam for the treatment of infections caused by Pseudomonas. So as we know that ceftazidime has a very high potency for treatment in Pseudomonas, but due to the resistance and CREs, Pseudomonas also had a resistance for this ceftazidime. So Pseudomonas, can you switch to the next slide, please? So the Pseudomonas is a opportunistic gram-negative pathogen. So It is responsible for approximately 5 to 14% of all nosocomial infections or healthcare associated infections, and 16 to 40% of the cases of ventilator associated pneumonias. So, will ceftazidime avibactam has a role for this treatment? Yes, it does have a very high role, and the patient with predisposing factors such as severe burns victims, with those who have reduced uh, immune function, and those admitted to the intensive care units are at increased risk of these infections. So the patient with also cystic fibrosis also having a likely chance of having this bronchiectasis and may develop chronic or recurrent infection. Moreover, the WAP and the COVID 19 has hit a hard, and we are seeing that we have nowhere to go. So basically, the WAP and the Pseudomonas, all these things are leading down to one only thing, that antimicrobial resistance. So ceftazidime avibactam also may have the potential important role in management of serious or complicated Pseudomonas infection, including those which MDR and XDR strain. XDR stands for extreme drug resistance, and ceftazidime avibactam also offers a good empiric treatment option for the patient considered at high risk of MDR gram-negative infections, which included venom resistance pneumonia infection. So this was a retrospective observational multi-center study where the ceftazidime avibactam therapy for the Klebsiella pneumonia with the carbapenemus producing KPC strains were observed. The multivariate regression analysis used to identify the variables independently associated with the 30-day mortality was observed. Results were adjusted for prior score for receipt of ceftazidime avibactam combinations regimens versus ceftazidime avibactam monotherapy. So the question comes down whether ceftazidime avibactam to be used in monotherapy or should be used in combination. When we are dealing with organisms like KPC, and we are having the carbapenemus over there, and we are having this molecule, we will prefer the combination therapy. The combination of ceftazidime avibactam along with astronome. So astronome is also a very old drug and very much popular. So the combination of ceftazidime avibactam of along with astronome is preferred over the ceftazidime avibactam monotherapy. So if we see to the next slide, we will see that in bloodstream infections. Come down to the next slide, please. If we see in the bloodstream infections that the ceftazidime avibactam combination has the higher rate of cure. The flowchart was demonstrating the cohort, and if we see in the other comparative study in UTI, in lower respiratory tract infection, along with abdominal infection and in other infection, the combination of ceftazidime avibactam along with another antibiotic is very much having a potential resistant infection selected for resistant against carbapenems in Klebsiella and other crackle or prospective multicenter studies. So this study is quite a bit interesting because we usually get the question, sir, which to use, colistin or ceftazidime avibactam. So there was a comparative study among this, and the efficacy, safety, and the benefit risk all were analyzed, and the extraordinary efficacy outcome were based on the disproportion at the 30 days after starting the treatment in home but not observed to die in the hospital versus the hospital death. Everything was analyzed and it was published in IDSA. So coming to the next slide, we can see that the patients which were treated with ceftazidime avibactam was 38, where the patients treated with colistin was 99, and the total sample size was 137. So the time of treatment was 3, and the colistin was 2, and for all it was 3. So at the end, which we can see is that the carbapenem organisms were having resistance. So due to the treatment, median was around 52, and for ceftazidime avibactam it was 10, where in the colistin it was also 10. Additional antibiotics were not used in the case was 14, and in the TG cycline was given in 12 patients, and amikacin was given in 6, gentamicin was in 12, and Fotramoxazole was given in 4, and carbapenem was given in 11 patients, and fosfomycin was given in 1 patient. So in summary, the evidence was the ceftazidime avibactam was superior over colistin in the initial treatment and infections caused by Klebsiella and immunocarbapenems. This use of ceftazidime avibactam was associated, especially due to decrease of all cases and hospital mortalities, and it is beneficial